Hello and welcome, everyone. My name is Susan Hearn, CEO of GME Solutions, and I'll be the moderator for today's webinar, Emerging GME Financial Trends. This is the third webinar in our GME Financial Management series. The objectives for the presentation today are as follows. Participants should be able to introduce recent changes to regulations related to GME finance and expansion, explore the various opportunities in which hospitals can expand their GME footprint, understand how to receive additional CMS funding in relation to GME, and discuss how Germain is involved in these strategic processes. Before I introduce today's speakers, there are a couple of housekeeping items to share. Participants have been muted upon entry into this session. However, that doesn't always work. So if your audio is showing is unmuted, please change that to mute to eliminate background noise during the presentation. We've made every effort to reduce technical issues with the webinar presentation. If you have problems of any kind, please indicate them in a private chat to Hunter Rich on the platform. The slide presentation webinar broadcasts are provided exclusively for the use of registrants and should not be shared. Reproducing, distributing, or transmitting any such materials or the live presentation to any other group or individual requires express permission from Germain Solutions. If you have any questions throughout the session, please submit them in the chat feature. We'll be answering questions as they come up, as well as during a dedicated question and answer time at the end of the session. If we're not able to get through all the questions in time allotted, or if you have a question you don't want to include through the public methods, you can have the opportunity to submit them via email afterwards. Abby Wilson will be serving as our chat facilitator today. Every registered participant for this session will receive an email containing a link to our survey so we can obtain feedback about the webinar. The survey is brief and we encourage your comments. Now let me introduce our speakers. We have Scott Mason, Manager of Finance, and Margot Flowers, Consultant, who will cover the recent changes in industry movement and graduate medical education funding for both current and new teaching hospitals. Scott provides extensive experience in financial projections and performance utilizing methodologies that incorporate Medicare cost reports and Medicare GME reimbursement. Margot's focus since joining the Germain team has been on analyzing hospital and clinical data, developing financial projections for residency and fellowship programs, as well as assessing program feasibility at non-teaching hospitals. She has experience working with large health systems to determine optimal strategic plans surrounding graduate medical education. Their full biographies are included in the webinar materials. Now let me turn it over to our speakers.
Awesome. Thank you for the introduction, Susan. All right, well, we'll jump in here. Thank you all for spending your time with us this afternoon. So we have 5 main areas that we'd like to cover today as far as the industry movement. The first one is the Consolidated Appropriations Act, which there's 3 different sections that we'll go through. Affiliation agreements, talking about what the benefit could potentially be to individual programs as well as to health systems. Rural designation, this is something that I will touch on, and Margot will also provide some additional clarification when she goes over the IPPS final rules for 2024. State funding, the trends that we're seeing in relation to state funding, how those could potentially be factored into making decisions for growing graduate medical education in respective states. And as I mentioned before, the IPPS rules, Margot is going to walk us through that section, which has 4 or 5 different areas to talk through. If you do have any questions and when we're going through here, please feel free to throw them in the chat. I do have it open here, and we can probably answer those as we're going through. All right, so kicking off here with the Consolidated Appropriations Act. So this was actually enacted in 2020, and they didn't really pass the guidance for it until 2021 to actually be implementing or utilizing some of these sections. The one piece from our point of view, which was encouraging compared to a lot of other acts that have been passed in the past, there were actually 3 sections that were applicable to graduate medical education, which is great in our opinion. And all of them were really targeted around giving hospitals and health systems opportunities to grow their graduate medical education caps in various different ways. So we'll jump into some of these different opportunities that they outlined. So the first one is section 126. This is one that I feel like was very well broadcast and everyone was aware of this opportunity. But the actual execution of it from CMS was very interesting, as it was a little bit different than I think what people had initially understood the distribution was for. And I'll jump into each one of these in a little bit more detail in the following slides. For Section 127, this was the opportunity that allows rural training programs outside of simply just family medicine. And we'll talk about how that can benefit not only the rural sites, but also the urban sites that participate within those programs. And then Section 131, this allows for hospitals that previously accepted residents, whether unknowingly or knowingly, and they had a very small cap set, or their PRA or per resident amount was tarnished. So this is something that we'll talk about here in a little bit. As I mentioned before, all of these had the best intentions, and we're very excited from our point of view to see additional opportunities for hospitals and health systems to teach additional residents and more importantly, receive more funding from CMS. So the first one is Section 126. How they outlined this was to distribute 1,000 additional funded FTEs over the next 5 years. Each hospital can receive up to 5 slots or 5 FTEs per year. At this point today, where we stand, 2 of these rounds have already occurred, and 1 of the distributions has occurred. The next one is set to occur in February of 2024. So this really gives us 3 additional opportunities to apply for these CAP positions and hopefully receive these. It's a pretty straightforward, or should I say, it's really just paperwork to show that you could apply for these different areas. That 40% of these positions, or 40% of the 200 positions awarded per year, are going to go to these different categories. The rural areas, whether hospitals operating over their cap, in states with new medical schools, or you're in a health shortage physician area, or a health shortage physician area. So when we're going through and doing these, the most important piece of this is they want to see expansion of existing programs or new growth. The common misconception for this opportunity was that it was a cap release, a cap relief valve, and hospitals that are operating over their cap, they could apply and receive additional funding, but that's really not the case. What they were trying to do is, in essence, create 1,000 new residents or fellows participating across the country, not just giving cap to hospitals that were hospitals that are operating over their existing cap. So in March of this year is when the next round closes. And if there is anything or any questions specific to that, we're more than happy to help every step along the way. The one last thing that I'll mention is in February. That's when the second round will be awarded. They said they'll do it by February 28th. Last year, I believe it was earlier or mid-February. But it is nice at falling at that point, because you can change your resident quota if you were to apply to those programs and receive cap. So then you could increase your quota and actually fill those positions for this upcoming year. And as I said, if you guys have any questions, please feel free to put those in the chat. The next one is Section 127. And as I mentioned before, this is really an attempt to open up the opportunity for training in rural areas more so than was previously allowed. Between the ACGME and CMS, there's not a lot of similarities, but the one thing that ties them together is that in order for hospitals to receive CMS funding, they need to be an ACGME approved program or a CODA program or a podiatry program. And it specifically lists the ACGME in the CMS legislation. Previously, the only rural programs that existed was a family medicine rural training program. And with that, only family medicine programs could take advantage of this opportunity. So what Section 127 did was it allowed for specialties outside of family medicine to start these new rural programs. And we call them the hub and spoke model, with the urban site usually providing the first year of training, and then the rural sites providing the second and third years of training. The best benefit about these programs is that both the urban sites and the rural sites create cap for those new programs. But the one qualifier here is over 50% of the program has to occur in rural areas. So as I mentioned before, this is normally set up where the first year is at the urban site, and then the second and third year of that residence training is in the rural site. So they would have about 2/3 of that training in the rural site, therefore meeting this requirement. So when we're looking at specifically in the rural sites, we throw around the word rural a lot, and we'll talk about here in a little bit rural reclassification or the rural designation strategy. For these specific opportunities, these have to be sitting in true rural areas, serving rural communities, not hospitals that are sitting in urban areas and rurally reclassified. So this is really an effort to get physicians into the rural area, not necessarily to let the loophole occur and just get more physicians training in the urban area. Last thing I'll say on this is both CMS and in tandem with this, reduce the minimum program size of a lot of their programs, which is great, especially the primary care programs. So this allows for a real new program to be started with the majority of it happening in the rural setting, rather than some of these larger programs that they used to be, because they never could have been supported in these rural areas. And furthermore, you can add on a rural training track to an existing, say, family medicine program or internal medicine program, and this would create new cap both in the urban site and in the rural site. So just a question in the chat: if the rural program fails after 5 years, do you lose the cap? Do you lose the increased cap spots in both institutions? Well, I sure hope that the program does not fail after 5 years, but for these programs, similarly to the cap at an institution, it's built the same way. So if you have cap that's built at an institution, that cap stays there, even if that program were to close at the end of the day, as long as you go through enough time to get that cap assigned to the institution. If the program were to close and you had orphan residents, normally that cap is potentially used to share to those other institutions. It's not required, but normally it's shared with those other institutions to help those residents graduate and make sure that they're able to finish their training. What if the 2020 census changes rural to urban designation? And that's for a specific location. And if that changes the actual CBSA or the census region, then that hospital would then qualify to be a spoke of this rural training track program. So that's definitely something to monitor year over year to make sure if there is a change there, they could now participate as the rural site of these training programs. Thank you for the questions. The next one is section 131, and this is an opportunity for hospitals to reset their per resident amount or their FTE cap. And when we say per resident amount, we specifically mean the amount of money that is part of the DGME funding formula. So the per resident amount is assigned to a hospital in their first year of training residents over 1.0 FTE. And this is then applied to the funding mechanism and multiplied by the Medicare utilization in the count of residents in order to calculate the DGME reimbursement. So the PRA is set by the lower of two items, either the costs that you put towards the GME program or the regional average for the per resident amount. So it's the lower of the two. What some hospitals did inadvertently was they accepted residents to come in from other institutions, and they didn't account for any of the costs related to training those residents. So it takes the lower of the two. Since you didn't claim any cost for your per resident amount, it is essentially zero and knocks out the whole DGME funding opportunity. So CMS looked at this and they found that there were many hospitals across the country that had this either very, very low cap that had been set, usually inadvertently, or their per resident amount was set at zero, because they just didn't know exactly how the formula worked for setting that PRA. And so what they did was they gave these hospitals, and are still giving these hospitals, an opportunity to reset both their PRA and their funding cap if they meet these different criteria. So the PRA is a little bit more straightforward. If you need to reset that, you can work through and get that reset with CMS or with your local auditors. But for the FTE cap, there's specific requirements that you have to have that you can't go over certain amounts. So the first one is 0 FTEs. If you're claiming 0 FTEs, then you're a non-teaching hospital and you have a new cap development period. And this really doesn't apply to you because you can create new funding cap for new programs. If you have less than 1.0 FTE before 1997, the hospital is eligible for Section 131 and you can reset your cap. And I want to be very clear here because a few of our clients have exactly 1.0 FTE, and it has to be less than 1.0 FTE. We have been able to work through and be creative about exactly how 1.0 FTE was set and demonstrating that maybe it's a little bit less than 1.0 than just exactly at 1.0. But how the rules are currently written, it says less than 1.0 FTE. After that, if you have less than 3.0 FTEs, it's 3 or less FTEs after 1997, the hospital is eligible as well. If you have more than 1.0 FTE or 3.0 after 1997, this hospital is not eligible. So for example, we've seen a couple hospitals have 1.1 FTEs on their 1996 cap. This makes you ineligible to receive this funding or to get this reset. Another example is we've seen say 3.5 FTEs on their cost reports in 2005. As soon as you go over that 3.0 FTEs, you are not eligible for this reset of your cap or PRA. The last thing before I jump to the question in the chat, you do have to start a new program for the cap reset by July 1 of 2025. We were initially under the understanding that you had to start all programs by 2025. So say if you want to start 2 new programs, they both had to be started by July 1. But upon recent responses from CMS, as long as you start 1 program by July 1 of 2025, this resets your cap development period, and then you have a 5-year cap development period, similar to just a non-teaching hospital that everyone's familiar with. So one question, what if the hospital does not have a training program at the hospital, but claimed residents and still does have rotators with the transfer of the cap? The PRA is established and is a good PRA at the current state, but there is no cap set. Does this still prohibit any new cap for new programs? So what I'm reading here, and please correct me if I'm wrong, you're accepting residents, you're receiving some, you set your PRA at a correct number, but the cap is not there. It historically had been the mere presence policy, where if residents were rotating in, as soon as you have residents, specifically residents from a new program, it triggered the cap development period and would set your cap for the program. If these were resident rotations from an existing program, which is a differentiator, which is sounding like the example that you're providing here, if you're just claiming the residents, you still have the opportunity to create a new cap. Since these are from an existing program and you set your PRA, you can set a new cap. So for example, if you needed to start a internal medicine program now, you could start this, and in essence, it would trigger your cap development period, and you could start whatever programs you would like in that 5-year cap development period. I hope that answered your question, Victoria. Are there any parameters for resetting the PRA, and how do you go about this? Good question. So the parameters are a lot more limited for the PRA, thankfully. And for that information, how we've done in the past is we've worked with the auditors, and the auditors have said, yes, you meet these qualifications, and we can work through and reset your PRA through a couple emails and communication with them. If that's something you just want general guidance with, we'd be more than happy to help you, or I can just follow up with an email to make sure you get exactly that information you're looking for. Is the PRA public information that can be accessed somewhere? So I guess it's a two-part question. The PRA is separate and distinct to each hospital. And in addition to that, there's also census regions where the PRA is set. If you don't have 3 teaching hospitals within your immediate CBSA area, it then goes to the regional census area. So all of those are public for all hospitals. It's a number that's reported on their cost report. So you can get that information. If you do have specific ones, Mike, that you need, please feel free to reach out to us. We can make sure that you get that information for whatever information you need to use it for. Are we eligible for both DGME, IME with building of a new program? Correct. Yes, you are. You can build both as long as you have not triggered that cap development period in the past, but it sounds like you're just receiving cap via Medicare GME affiliation agreement or something of the like, claiming existing residents receiving the funding, but that more or less protects your ability to create new funding in the future. All right, thank you for all the questions. That leads us into the Medicare GME affiliation agreements. So the Medicare GME affiliation agreements is a way that hospitals can shift their IME and their DGME cap from one hospital to another. So the cap is set, either it was set in 1996 or it's set at the conclusion of a cap development period. That cap can then be transferred from one hospital to another via Medicare GME affiliation agreements. There's really 2 different reasons that we see hospitals and health system utilizing these affiliation agreements. One is for a specific program. If we know for a specific program, we have to send pediatric surgery out to another hospital, and that hospital wants to have some type of funding for the program while they're there, we can transfer cap from one hospital to another and use that funding, or the hospital that's providing that pediatric surgery experience, they can receive that funding for the training when the resident is in-house. So that's one opportunity that we normally see, and it's specific to programs. The other opportunity is more of a system-wide level. As we were kind of talking about a little bit before, the per resident amounts related to the DGME formula is different for every hospital. And similarly, the IME reimbursement is different for each and every hospital. And so one capped position could be worth $100,000 at one site, but it could be worth $175,000 at another site. So this is something where we want to, when we're looking at a system and we say have 5 or 10 hospitals to look at and say, where is this worth the most money? Because we could potentially shift these to help increase the reimbursement to make it a better training experience for the residents. That's something that can be analyzed in shifting the cap from one location to another. We do need to make sure that there is a cross-rotational agreement between institutions if we're transferring cap. But that's something that can be looked into to make sure we have some type of experience. And normally paying for the travel and paying for the housing of sending individuals out to another location, it's normally worth it in relation to the Medicare reimbursement that would be available. One other kind of misconception that we normally get from Medicare GME affiliation agreements is this is a 1-year, one-time cap sharing agreement between 2 hospitals. This is not something that once you share this cap, it's gone forever. These are 1-year agreements, and if nothing happens after that year agreement, the cap always reverts back to the home hospital. So this is something where we want to make sure that people feel comfortable doing this, and it's not that if you do this once, it's gone forever. It'll always come back to you because that's how the legislation is set up, even if nothing is done between the 2 institutions. Question in the chat: is it possible to transfer cap to another hospital if there's excess cap at our hospital, but there's no rotators between the 2 hospitals? Thinking about how to protect our cap long term. Absolutely. So There's potential there. It depends if the hospitals are within the same institution or within the same health system, excuse me, or if they're kind of separate and distinct health systems. We'd have to kind of look at that as a specific case-by-case basis. But there is some more flexibility if they're within the same institution. We would still recommend to try to set up some type of cross-rotational agreement to try to minimize any red flags there. But that's something we could potentially look at to see if there would be a specific opportunity for your case. Okay, so jumping into rural designation. So this is an opportunity that was set in a precedent about 5 to 7 years ago by Geisinger Medical Center. And this is something where it allows for a hospital to be paid at urban wage index rates, but be able to have the flexibility of having the graduate medical education benefits of a rural hospital. So who qualifies for this? And this is always strange because we think about rural areas. But if you're over 275 beds, where 275 beds came from, we are unsure, but that is the threshold. So if you're over 275 beds, it's generally easy to qualify. If you're under 275 beds, there are still ways to qualify, but you just have to demonstrate the population that you're serving is from a rural area. So that's something that can be done, but it's a lot more straightforward if it's over 275 beds. The one thing to keep in mind for this strategy is this is a hospital strategy. There is ancillary benefits for graduate medical education, but this is not a rural designation strategy for GME. This affects the entire hospital. And normally for these type of opportunities, we work very closely with the reimbursement team because we want to make sure that if there are any negative impacts, we can quantify those and show how that may be able to be offset by the potential increase in graduate medical education payments. So we normally see 3 different reasons for hospitals wanting to pursue this strategy. So one of the benefits is an immediate 30% increase to your 1996 IME cap. So if you have a cap of 100 on your 1996 IME cap, moving forward after you elected rural reclassification, you would have a cap of 130 IME cap to support whatever programs that you want. And remember, those aren't program specific, but the great benefit is, say that if you're training 150 residents and you have a cap of 100, you would immediately get funding for 30 additional residents from this bump in the cap. The second one that I think is probably a little bit more popular is the ability to build new IME cap on a program by program basis. And what this does is you really just follow the rural development rules that if a hospital sits in a rural area, they always have this 5-year cap development period for each program rather than a one-time 5-year cap development period for the hospital itself. So this allows hospitals that were previously capped to then be able to create new cap on the IME side for new programs that they want to start. The last one is non-GME reasons. This is something related to wage index and where you're classifying the hospital, and there's potential benefits to being a rural hospital rather than urban because you could classify to a more financially advantageous wage index area. But even if you're doing it for a non-GME reason, you still get the GME benefits for the reclassification. This is something where over 600 hospitals have done this, and we expect that this year alone, I think there's going to be over 100 hospitals that are doing this or maybe more. And Margot will get into that a little bit more here later in the presentation as to why so many this year are starting to reclassify compared to the previous years. So quickly, just going over this one more time. So the benefits, you get a 30% increase on your 1996 IME cap. You're able to build IME cap on a program by program basis. And if this is something that you have questions to say, well, how much is the IME cap for what we'd be creating for new programs? We can help calculate that and show exactly what that would be. You can factor that into your projections to make sure you have a financially viable program moving forward in the future. One of the challenges or one of the items to keep in mind is this is a complex process, but the other one is this designation needs to be maintained for 10 years. And this is something where there's not anything that's necessarily bad about classifying back, but that 30% increase that you would get, it would be taken off if you don't maintain the classification for 10 years. We don't see any negative consequences at this point in time for being able to stay a rural referral center or a rural reclassified hospital. So this shouldn't be a downside, but it's definitely something we want to mention because some people get a little bit hesitant of wanting to change and stay that for 10 years. Okay. One other trend that we just wanted to discuss is state funding. State funding is something that is very prevalent across the United States. From the recent AAMC study, 44 states currently have graduate medical education funding under the Medicaid program. And this increased from 43 in 2018. But this is something that we just want to put out there where you're probably receiving some type of funding from the state level. And it's important for you all. I know that going through the budget sessions every year, it's always saying, how do we justify graduate medical education? How do we show that we are breaking even or we're making money for this institution? It's not just we're not just losing money year over year. We want to make sure that these state funding mechanisms are also included within your projections to show the full benefits that graduate medical education is providing outside of simply just the CMS funding that everyone's pretty aware of. So if you have questions about that, we normally see a lot of the guidance in the state plan amendment, and we'd be happy to kind of work through that. If you have questions about specific states, we have worked all across the country, and that's something where we'd be able to explain to you exactly what those spending mechanisms are and how they could potentially apply to you now and into the future if you decide to grow more programs. All right, and that's it from my side of things. I will turn it over to Margot, and she's going to walk through the IPPS final rules for 2024.
Thanks, Scott. So every year, CMS releases updates for the Acute Inpatient Prospective Payment System, or IPPS. The rules are initially proposed in April, at which point CMS will accept comments, and then the rules are finalized and published in August. These updates can pertain to anything regarding inpatient Medicare patients, but we're always on the lookout for what is relevant in the graduate medical education space. And while this doesn't happen every year, but the 2024 final rules had updates that significantly impacted GME. In almost every case, the updated rules allow for the expansion of GME at teaching hospitals. So there are 6 on the screen here, and I do have a slide for each of them, so we'll just go into each of those in a little bit more detail. Section 5506 of the Affordable Care Act authorizes the redistribution of residency cap slots after a teaching hospital closes. This has now happened 20 different times since the Affordable Care Act was established back in 2010, the 20th being announced on the proposed 2024 IPPS rules. So St. Vincent Charity Medical Center, located in Cleveland, Ohio, stopped all of their inpatient services late last year. They had 56.73 IME and 64.66 DGME FTEs that are now to be distributed as round 20 of Section 5506. To qualify to receive a portion of these cap slots, hospitals should have submitted an application to CMS by July 10th of this year. So while this opportunity has now expired, it's important to continue to monitor any of these closing hospitals and also the announcements for the next round of Section 5506. Now, this part is not exactly new to the 2024 IPPS rules. It is still relatively new and will also provide a little bit more context for some of the other things I'm going to talk about. So we'll cover critical access hospitals. So critical access is a designation that was established to keep essential services in rural communities where they're needed. Facilities that qualify for this designation have 25 or fewer beds, are 35 miles away from another hospital, and also provide 24/7 emergency care. Because critical access hospitals are not reimbursed under IPPS, they are not eligible to receive DGME and IME payments like we're used to in short-term acute care hospitals. However, they can be reimbursed for GME activity in one of 2 ways. The first being incurring costs directly, and second, by functioning as a non-provider setting. We often find it to be more beneficial when critical access hospitals choose to be funded as a non-provider setting, just because they can be then claimed on a partnering short-term acute care hospital's Medicare cost report. The reimbursement rates of those short-term acute care hospitals almost always exceed what the critical access hospitals would expect to receive through the cost-based reimbursement option. So the designation of a rural emergency hospital, or REH, was introduced on the Consolidated Appropriations Act that Scott went over and was established back in 2020. Similarly to the critical access hospital designation, rural emergency hospitals were designed to improve access to care in those rural communities. This designation allows facilities to continue to provide emergency care without supporting inpatient volumes. And so the 2024 IPPS rules establish that the rural emergency hospitals can be funded in terms of graduate medical education the same way as critical access hospitals, either through the cost-based reimbursement or as a non-provider site. This is great for residency and fellowship programs because it allows health systems to send rotations out to these rural sites to have more providers in these areas of needs while also not suffering in terms of reimbursement. Now moving on to the rural designation portion. Scott earlier mentioned the rural designation strategy as a way for hospitals to be rurally reclassified and to expand their IME funding. The regulations that allow for this strategy have been in place for a few years. Like we said, 600 hospitals have done this already. But the 2024 IPPS rules make it even easier, or at least more financially feasible, to implement this strategy at other hospitals. So previously, hospitals that were rurally reclassified were ineligible to receive capital dish payments. And this is separate from GME. It just completely eliminated their eligibility to receive them. Usually the benefits of the strategy would outweigh the negative of missing out on these capital dish payments, which is why so many hospitals have already been successful in implementing the strategy. But the new rules state that as of October 1st of this year, rurally reclassified hospitals will no longer be subject to the loss of capital dish payments. In other words, hospitals that have done the rural designation strategy will still receive the capital dish payments where previously they would not. So if that was a barrier to pursue this strategy in the past, it is no longer applicable. A question came through in the chat. Can you explain capital dish payments? And Scott, I'm going to pull you back in for that one.
Yeah, no problem. This is just the capital DRG payments. This is an add-on similar to that are help to offset some of the capital investments or capital operation costs related to disproportionate share. So it's normally a smaller piece to the puzzle, but for some of these larger hospitals with large disproportionate shares, it can be a good chunk of money. So but I hope that helps, but
will that result in the loss?
Samuel, I do not know the answer to that question. Related, it says, will that result in the loss of PPAP, SNAF payments in Michigan? I'm not as familiar with those acronyms, but I will get back to you after we finish up this webinar.
Thanks, Scott. So the one other rule from the 2024 IPPS rules that impacts rural designation is in relation to the rural floor. So the new rules now include rurally reclassified hospitals in all rural wage index calculations. Because these hospitals are geographically urban, their wage index values are often higher than that of the rural floor. So by including them in these rural wage index calculations, in many cases, the rural wage floor has been increased. So as a result, there has been a dramatic reduction in the number of different wage index values to be paid for each state. CMS estimated 646 hospitals will be paid at the rural floor in fiscal year 2024, which is much higher than in the years past. So what does this mean for hospitals in pursuit of the rural designation strategy? With the increase in the number of hospitals of all designations paid at the rural wage floor, it is less likely that your facility will see a significant financial hit in the first year, where in the past you would have to expect reduced payments for a period of time while you're at that rural floor. if you're already operating at the rural floor, there's no negative financial impact of pursuing the rural designation strategy. So
And see, oh, go ahead. Go ahead, Mark. I'm sorry.
it's just a lot to say that if you thought about doing the rural designation strategy in the past, but have kind of held back because either of these two reasons, now is definitely a good time to kind of redo that analysis and see if it would work for you.
And Samuel, just going back to your question, with it, if it's a Michigan designation specifically for those payments, this is a federal designation related to the rural reclassification. I would be surprised if that would negatively impact how the state's identifying the hospital, but I will follow up on that in more detail with you later this week.
Okay, the final GME related topic of the 2024 IPPS rules relate to the Medicare cost report. First, the rules now more clearly indicate how the prior year intern and resident to bed ratio, or IRB, is calculated. The rules now state that this ratio may be adjusted to properly reflect an increase in the current cost reporting period's resident to bed ratio due to residents in a new GME program or new rural track program, a Medicare GME affiliation agreement, or due to residents displaced by the closure of a hospital or residency program. The inclusion of this language just clears up what was previously a little bit more ambiguous. And lastly, the rules announced the Medicare Advantage DGME reduction factor. This is something that is updated year over year, but in 2024, the reduction factor will be 3.27%. This is relatively lower than it has been in the past, which indicates that the GME payments will be reduced by less, which means more funding for those relying on these payments to kind of support their programs. So again, more good things, even though these are just kind of repeated year over year. And I think that's all in regards to IPPS. So if there's any questions, again, put them in the chat, but I'm going to hand it back to Scott.
Absolutely. Yeah, and Margaret, thanks for going through those items. I think just kind of putting a bow on this specific webinar, but we've really been seeing a lot of positive changes, both at the federal level and at the state levels related to graduate medical education. And there haven't been a lot of opportunities or discussions that we've been aware of related to payments being pulled back or opportunities being restricted related to graduate medical education growth. The federal and state levels are seeing the benefits of graduate medical education and want to try to get more physicians. The states want to get more physicians in their respective states. And then obviously at the federal level, they're trying to get more across the country to hopefully address the ever-growing physician shortage that's projected in the next 10 to 20 years. So really kind of our question is, how do some of these industry movements fit into your system's GME strategy? A lot of places that we've talked to, they previously thought that there was no opportunity to create new CAP, and they were just kind of stuck with the one family medicine program they had or the one internal medicine program they have. And utilizing rural designation, they're now able to create new CAP and start more programs to support the communities and the health systems that they're within. So there's a great opportunity there with some of the IPPS rules, being able to claim residents in critical access hospitals or being able to claim residents in rural emergency hospitals. This is a great way to make these programs financially viable in rural areas compared to just some of the cost-based reimbursement that had historically been available. And then with the Consolidated Appropriations Act, it's really great to see that they are making some efforts in putting emphasis on these rural areas to be able to send physicians out to these rural areas, to be able to create funding, not only when they're in the rural areas, but also in the urban areas as well, because normally we can't get 100% of the experiences all in a rural area. So it's really great to see that there are both efforts from the state and federal level in order to get more funding for graduate medical education across the country. But with that being said, like our strategy process, you can see here at the bottom, this kind of just walks through how we normally take in the information, how we synthesize that, how we project out different financial and feasibilities of these programs, and then really getting into what those strategic recommendations would be. And each and every location is a case-by-case basis. Obviously, we have all these rules and opportunities at our disposal, but it's really a pointed strategy to see what would be the best fit for each and every one of our clients. But I believe that kind of brings us to the end here. We very much appreciate everyone who has been on for all three of the webinars. But if this was your first one, we very much appreciate that as well. And we'll kind of just open it up now. If there are any other questions, please feel free to put them in the chat. Diane, I believe the slides will be sent out with the survey after this presentation.
So I know we answered a lot of questions throughout the process. If you do have any questions that are outstanding after today's presentation, please email Hunter Rich, hrich@germain-solutions.com, and we'll ensure that we get an answer off to you. I want to thank our presenters today for the information and the insights that were provided. In wrapping up our session, I want to thank you all for participating. As noted earlier, you will receive an email this afternoon with a short survey to complete, as well as a copy of the presentation. And for additional GME educational content, we will be hosting more GME webinars next year. Upcoming details and registration information will be found on LinkedIn as well as our website. If you're interested in any future webinars, please complete the survey after today's webinar, and our marketing team will ensure that you receive all future webinar promotions. And to be included in any other future announcements, please follow Germain Solutions on LinkedIn or visit us on our website. Thank you again for your participation in today's webinar.
Thank you all. Have a great rest of your day.
Thanks, everyone.